Good afternoon, and thank you, SAGES, for allowing us to present our work on the predictive factors and clinical outcomes of pleural tears in laparoscopic esophageal surgery. These are our disclosures, of which none are relevant to this study. So over the last 2 decades, laparoscopy has become kind of the mainstay surgical approach for the management of benign esophageal diseases. There's inherent risk for parietal pleural tears, which can lead to intraoperative capnothorax, which can then lead to potential hemodynamic and respiratory instability, and may require the placement of tube thoracostomy. So looking at the literature, reported rates of intraoperative capnothorax has been reported anywhere from 2 to 15%. But there's limited data on both the clinical implications as well as any preoperative risk factors. More importantly, whether or not tube thoracostomy is needed in the management of acute capnothorax. So the purpose of this study was to identify and analyze predictive risk factors and look at clinical outcomes of pleural tears during laparoscopic esophageal surgery for benign disease. So this was a single surgeon prospective database collected between the years of 2004 to 2011 at our tertiary referral center. And the primary outcome was the presence of intraoperative pleural tear. Any hemodynamic or respiratory instability, which was defined as the requirement of deinsufflation of pneumoperitoneum or the administration of vasopressors, was recorded prospectively at the time of the operation. So in total, we had 382 cases, and pleural tears were noted in 12% of these cases. When comparing pleural tears by operation type, we found a statistical significant difference in the rate of pleural tears by operation type, with a marked increase in pleural tears noted during paraesophageal hernia repair. When looking at pleural tear by demographics, we specifically looked at gender, age, and BMI, but we did not find any statistically significant difference in the demographics. As well as looking at operative factors, including who the primary operator was, whether the procedure was a reoperation or the need for adhesiolysis, we did not find any statistically significant difference in operative factors. So we found 13 of the pleural tears, 13 of the 44 pleural tears that we had resulted in some level of hemodynamic or respiratory instability, which accounts for about 30% of all reported pleural tears. However, in none of these cases did we require tube thoracostomy in the management. Postoperative complication rates were not significant between the two groups, nor was the overall length of stay between the two groups. And no mortalities were seen in either group. So in conclusion, parietal pleural tears occurred in 12% of laparoscopic esophageal surgeries for benign disease, of which 30% of the pleural tears resulted in some level of hemodynamic or respiratory instability. However, all cases of instability were transient in nature, and none of them required invasive maneuvers. So our group concludes that pleural tears have no significant impact on postoperative outcomes or complications. Thank you very much.